Okay. So yes, welcome again for those of you who haven't been on yet. We have a great set of presentations lined up for this evening. So we're really excited for everyone to be able to experience this. We want to also encourage those who have not yet submitted a form for this kind of event. This will really give you a great layout of kind of what these are meant for. We really want to give scholars and students the opportunity to really showcase their work and their amazing things that they've been working on within their communities, with their other AHEC centers. So we're really excited. Sorry, I'm just letting a couple people in. Kristen, I don't know if you wanted to say anything also before we get started.
I'm really excited about our speakers tonight. It's a pretty diverse group, so they have great topics they selected. And I do encourage everybody just to give it a shot. It's a great opportunity to present nationally as a student. So we will accept applications on a rolling basis, and then we'll notify you when the next presentation is going to be. So if you're going to be around for the next year, go ahead and submit your ideas and we'll start to look over them. So thanks and enjoy the evening.
Perfect. So to kick us off, we have Jenna going first. And also throughout the presentations, if anyone wants to put questions in the chat, please do so, and we will go ahead and address those after the presentation. And yeah, just hand it off to Jenna.
Alrighty, good evening, everyone. Today I'm going to be presenting on a course I took called Occupational Spanish for the Physician's Office. My name is Jenna Goins. I'm part of the Big Bend AHEC Scholars in Florida, and I'm a third-year Doctor of Pharmacy candidate from Florida A&M University. So I just want to go ahead and share a link to my LinkedIn in case any scholars or potential scholars had any questions, either about the program in general or any interest in the occupational Spanish course I'll be discussing. So first, I'm just going to do a little overview of the program as well as acknowledgements to my instructor. So Liliana Irwin was my instructor for this course. She's a nationally certified medical interpreter, a state certified court interpreter, and also a licensed medical interpreter. And she's done this course several times as an occupational Spanish trainer. And I know actually tonight we have some people joining us that had their orientation to start the course tonight. So the overview of this program, it's a 3-week program in which most of your coursework is submitted through recordings. And then you also have a reference manual and professor feedback. I really appreciate that we squished learning the basic of Spanish into 3 weeks, because I know something like learning an entire new language is super intimidating, but I do think it's something that can help you develop as a professional and just learn another skill to be able to reach another population that may be lacking access to care. So the objectives of the program were to learn the most needed phrases based on your career. So throughout this program, most of the phrases that I worked on were related to pharmacy, since I'm a Doctor of Pharmacy candidate, and any type of conversation that I would be prominent to my area of study. So that was really important to me because, again, with just 3 weeks, we don't have time to learn everything, but it did give me enough to be able to effectively communicate on a basic level with Spanish-speaking patients. And then also just becoming comfortable with Spanish pronunciation. So the way that this worked is they picked a form of Spanish that could be understood by many different Hispanic populations, so not just specific to one region, which I also thought was very helpful and appropriate, just so you can reach a more diverse group of patients. Understanding answers to controlled questions. So one thing that was super helpful about this program was most of the phrases that we worked on and learned, we learned them in a controlled manner. So that way the response would always be a yes or no response, or something that we could predict to be a response. So it kind of like led the question to be answered in a way that would be easy for us to interpret and respond to. And also, since a lot of the questions were yes or no answers, we can basically get an answer non-verbally as needed also. So a simple nod of the head or shake for yes or no. And then final was create cultural awareness and competency. So we did learn a little bit about different Hispanic cultural aspects. And that was interesting because I didn't know a lot about it. And that was also helpful in understanding how to communicate with Spanish speaking patients. So next, I'm just going to talk a little bit about my experience with this course. So these were the benefits I personally feel I gained from taking this course. So I do have the improved communication. I think this will allow me to be a better pharmacist because I will be able to communicate with more patients than I previously was able to. Cultural competency, understanding different things that aren't normal for maybe the area I was raised or practice in, but may experience individuals that have different cultural aspects. And then if that's not enough to convince any potential AHEC scholars that were interested in this course, it's also a really good resume builder and a good way to meet new people and other scholars. And then I also just want to share that upon completion of this course, I mentioned it was a resume builder, everyone does receive a certification of completion. So that's also a little bonus. And that's pretty much all. I just want to do an overview of this so that potential scholars and also current scholars could see that this opportunity is available to them. So if you're thinking about becoming a scholar, I'm happy to answer any questions about that. If you want to reach out through LinkedIn or my email. And then also if there's any current scholars that are thinking about doing this program, I'd also be happy to answer any questions regarding that. Thank you.
Great. Does anyone have any questions for Jenna?
I do. Oh,
Great.
let me see. Hi, Jenna. So we're in the same class.
Hello.
But what was one of your favorite phrases that you learned in this course?
Yeah, so so some of them are mostly regarding medications. So I really appreciated that we had phonemic encoding. So that way, if you are a first-time Spanish learner, so I did it that way. So something I worked on is, are you taking any medications? So está tomando medicina. So I know it's butchered, but like I said, I did the phonetic encoding. So it works. It's not the best. And I do say it's a 3-week course, but we also have access to the guide and we're encouraged to continue learning them and memorizing any of the ones that will be pertinent to our field. And then also I completed this course on March 3rd. So I'm only about a month out of learning, but I will say that I do have access to the recordings and I'm still utilizing them to kind of learn different things that I think will be needed in my career. Did anyone else have any questions? All right, thank you guys. And again, my email was in the presentation or LinkedIn if anyone has any specific questions about the program they wanted to ask offline. Thanks, you.
Jenna. I think it's great that you know, it's the effort. Doesn't mean you have to have a perfect pronunciation. The fact that you're willing to try, I think is what's most important. So I think that's great.
And that's amazing. That is only, what, 3 weeks?
Yes, ma'am.
Yes, it's amazing. Good job.
Thank you.
All right. Well, thank you, Jenna. We're going to go ahead and transition into our next presenter. We'll be talking about the sensory stimuli adaptation to improve the efficiency of oral hygiene treatment in autistic children.
So everybody can see my screen?
Yes.
Yes. All right. Let me just make it smaller so I can. Okay. All right, everybody. So good evening. My name is Cristiane Rocha. I am a dental hygiene student from Miami-Dade College here in South Miami. And I'm freshman, I will be graduating next year. And my presentation, as Amanda presented, was the sensory stimuli adaptation to improve the efficiency of oral hygiene in autistic children. And just a little background, why did I choose, this topic? I had a past experience working as a coordinator for an oral health care program for many years, over 15 years. And as a coordinator, we used to take our program visiting schools, and we had the chance to visit multiple special needs schools and some schools with specific kids with autism. And I just noticed how both sides, the population had a very difficult access to care, finding professionals that were qualified and training to be seeing those kids. And on the other hand, the professionals that came to volunteer with us, they felt very uncomfortable and they didn't know how to treat those children, how to approach them. So then when I decided to become a dental hygienist, go back to school, I had no question about it. I say, this is a population that it needs attention, and I didn't find anything related to that. So I decided to research myself. So there is a need to consider ways to supporting children with autism to obtain their dental hygiene treatment without sedation and restraint. And I want to make it very clear here, I'm talking about dental hygiene, dental cleanings. The sedations and restraints may be necessary in some cases, in some extensive work when the child maybe need an extraction or a restoration. The sedation may be necessary regardless if the child has autism or not. But here I'm talking about regular preventive care, dental hygiene, dental cleaning. And usually for the children population, the dental cleaning is very simple. We don't use it too much instruments, is polish their teeth. So the approach that I'm showing here, it is what I would like to share that is possible without the sedation they restrain. And I have this quote when I was researching this information from Dr. Elizabeth Schick. She's connected with Autism Speaks. She has developed a dental tool kit that is available. We have the link we can share with you guys. And she has a quote that it really got into my attention. With the patient and understanding, many children and adults with autism can sit through a normal dental visit without restraint or sedation. In my experience, this involves taking the patient through procedures and using positive reinforcements to accomplish appointment goals. And that's my goal here. That's what I would like to share with you. I also believe on that. So the autism spectrum disorder. My presentation is not going to be talking about autism spectrum disorder. This is not my specialty, but I want to share with you guys an idea about and what is relevant to my career and what is relevant to my research. So when I talk about autism spectrum disorder, I may be talking about ASD. And this is a broad range of conditions marked by challenges with social skills. It is often associated with sensory sensitivities, repetitive behaviors, and nonverbal communication. And because autism is a spectrum disorder, each person with autism has a unique set of strengths and challenges. So those markers are important for me to understand, because this is going to help me make the modifications that will be necessary to better accommodate this population. So a little background, we have a fresh new background about autism. The CDC just released last month. This used to be 1 in each 44. Now it is 1 in each 36 children in the USA. They were diagnostic. And so this is very important for me because why? If I have the training or not, sooner or later, in some case, I will get a patient that has the spectrum. I will have I will need to have the ability to treat them. So it's very important for us to have the training. I'm talking about children, but it may be a lot of adults that are already going to dental offices and they may have the same issues. So a little other background that for me is very important, an estimate of 25 to 30% of this population may be nonverbal. And because I'm talking about children, usually this is it's very typical when they have a delay in speech, they have a delay in speaking. So if I'm treating children in a young age, maybe, you know, from 3, 4, 5, 6 years old, I may be treating a child that is not fully verbal. So I will need to find a way to communicate with the child or with the parents. Another research that really got my attention was the 38% of pediatric patients who visited dental units reported having negative experiences. In some cases, the parents reported the doctors were not able to offer adequate oral care to their children. And they have a difficulty experience when trying to have the dentist cleaning their teeth. So the dental professionals, they were not ready, they were not prepared. Oops. This is another research that now is showing the parents' experience. What they are saying about the dental office? Access to care. They have a difficulty to find the right dentist. And why this is important? There is a delay. There is another study that shows that usually this population, the parents delay to take their child to the dentist. When they take their child to the dentist, is already to treat restorative. There is already a cavity, is already a major problem. So my point is, we need to make this accessible for them so they will be able to keep their preventive visits to the dentist. And this is what with us, what we dental hygienists offer. It is the dental cleanings, the preventive, applying fluoride, making sure that this child will be seen every 6 months. They have a sensory about the sensory sensitivities. Parents were saying all the sensory devices just making him so uncomfortable, or the restraint. It was so upsetting to see him strapped into a jacket for procedures. Again, the restraint may be necessary in some cases. For dental cleaning, this is something that really needed to be discussed with parents, in my opinion. And we should be exhausting all the possibilities before offering the sedation and restraint. So this video, I would like you to, it's a short video, few seconds, but it's gonna show you how may be uncomfortable for a child or a patient that has autism and has sensory sensitivity, how noisy and how invasive going to the dentist is. So let me make sure that I will be sharing my sound. And you let me know, Amanda, maybe I can see you. Give me a thumbs up if you can hear that. So this is a short sample just to show you how noisy the dental office is. The dental professional is so close to the patient's face. It's a lot of things going on inside the patient's mouth. So for a patient, that it has sensory sensitivity, this is overwhelming. So we needed to find a way to break it down and start to work around the sensory, and so they will be able to tolerate a treatment. This may be uncomfortable if a lot of people report not being comfortable in the dental office, right? So what is the solution? I am bringing here to you all these, issues. So what is the solution? My solution was I had a hard time to find articles, anything new about the topic. So I started to research around the community. So I had friends that have kids with autism, and I was asking them, how was your experience at the dental office? And I ended up having the recommendation of 2 dental professionals that they are doing an amazing job. So what is great about this, I will be sharing here something that is being done already and is being a successful outcome. So unfortunately, those 2 dentists, they are from Brazil. I am originally from Brazil. I had an opportunity to interview one of them, and they were sharing with me their approach, what they are doing, and it is very similar what they do. So that this is showing to me that is if those steps have a very successful, they are very successful, and it's not that difficult to implement. So the first approach is the multidisciplinary approach. What that means? As a dental professional, it's very important for me to interview correctly the parents, to understand the child's individual needs, to what they like, what they dislike, so I can bring everything about this child to my dental appointment. And this can be included on the medical report. Usually, we have a medical report, we have to go through some questions, and so those questions can be included. I found some interesting questionnaires that is available in the Autism Speaks. They have a dental tools there that has, questions and a questionnaire very interesting to approach parents. And we also may be working as a professional team, working with the child therapist team. With usually the kids with autism, they will have a team of medical support. They will be doing multiple therapies, ABA therapies, occupational therapies. So why not to find with those therapists that they are with the child all the time, they are already interacting and teach them social skills and work as a team. So even before the child comes to my office, we can approach those professionals, work together, and ask those professionals to include the dental visit social skills into the child therapy. So the child will start to learn about what is the dental office looks like, what the dental visit looks like. That video that I showed to you earlier, this can be shared with the child so they can start to get familiar with the sounds. So this is a teamwork. So Dr. Klaus Santos is the first dentist that I would like to share his approach. He's a pediatric dentist in Brazil, and he's also a professor. And his approach was the desensitization and predictability. This is key. This is what I found in here. It's gonna be key and very successful for this population. So the desensitization process, it is where we start very simple. Brushing the child's teeth. I will show here a video that is no sound, but just for you to observe, he's showing using a mirror. The patient is looking. This patient is a child with autism with, low support. And so he's already sitting in the dental chair, what is a plus. And the dental professional is very close to him. So he's making the child to hold the toothbrush, so he's giving, power and authority for this patient to control, and indirectly, he's working and going inside with the touching, inside the mouth, inside the dental office. So this is a good start before you try any instrument. Here, he's already moving to an instrument. This is an instrument that we use to polish the child teeth. It's a totally different feel. It will have sounds, vibration, very different than a toothbrush. But again, he allows the patient, the child to feel, so they can feel comfortable before they actually do something. So this is moving from the toothbrush for the instruments. Tasting, the materials. Usually when we are going to be polishing the child teeth, we have a ProfiPaste, is a special toothpaste that we use in the dental office, and it has a different texture. It's very different than the toothpaste the child we're going to be using at home. Let them try. If they don't like it, maybe we're starting to polish their teeth with their home toothpaste. That's okay, and then we move little by little. And once they get used to the office toothpaste, make a note, their flavor preference, the color, so you can repeat every time they come to the office, you can use the same product. Tell and show, it is a technique. I'm gonna hold a little bit here. Tell and show, it is a technique that we use for children and that we use for patients with, maybe lower oral literacy, where we explain what we are gonna be doing, so the patient can be comfortable. For the children with autism, for this population, is very important. And so I'm gonna show, this is a video that has a sound, and I love this video because it really shows how the patient is comfortable. No, he's not fighting, he's very relaxed, and the dentist is able to scale and clean his teeth.
Mais cocô, olha isso. Na luz, vamos olhar na luz, Jadi. Olha aqui, ó.
So as you can see, the patient, is very comfortable and is not fighting, against the treatment, very comfortable. The only modification here that we have, it is the sitting position. Usually dental professionals, we are going to be sitting the patient in a supine or semi-supine. We are going to be laying down the patient. And here, the dental professional, the dentist, is treating the child in an upright position, what usually is more familiar to everybody. And that's okay. This is a modification that sometimes we learn at school, and it may be necessary for other pregnant women or a patient that has a back pain. So this is an easy modification. This is another professional that I met in Brazil with Tia Rô. Her name is Roseli Latronico. She's also a pediatric dentist, and she uses a very similar approach. Descentation, using the brushing. You're gonna see here, the difference here, this child is still not sitting in the dental chair. That's okay. She has a little table inside her operatory, and she's brushing the child's teeth. She notices the child doesn't like to talk or sing, because usually when we are treating children, we may be singing a song. So she notices the patient doesn't like. So she's brushing the child's teeth quietly. And the next step, you probably will be trying to move the child from this little table to the dental chair. But also toothbrushing was a technique used for the patient to be comfortable with the touch. This video is something also is my last video. I would like to share how comfortable this child is sitting. He has no autism, but this case was a patient that had 3 restorations to be done. The family couldn't find, Tia Ho was the 4th dental office that they visit. The other 3 dental offices couldn't treat him, and they got the recommendation to this dentist. So you can see how comfortable he is. Was no necessary any sedation. She was able to do the 3 restorations. They were small. In this video, she's using the light to cure. So she's finishing the treatment. She has a TV on the ceiling. So the patient is very comfortable watching the TV. No struggle, no crying, very comfortable. So my final considerations. Offering visits, offer a tour visits to the child to get familiar with the space and staff also can be a nice approach. Even before we do something, so they can know, the space, they can get familiar with the staff. Have available the visual aid cards. Usually the families will have those visual aid cards in case the child is non-verbal. So we may have some, but usually talk to the parent. If the child is non-verbal, bring it to the office, their cards, so we can communicate with the child the way they understand. And these measurements have been proven to reduce the anxiety and psychological stress among children with ASD and their families. So dental hygienists, in my opinion, need to learn and consider adaptation to supporting the children with autism. They deserve to have their oral hygiene without sedation or restraint, whenever is possible. In my final thank you, I would like a special thank you to my professor, Dr. Pino. I believe she's here watching me. She was my inspiration to continue this research. When we had a research paper to work with, I thought this topic, maybe, oh no, she said, no, go ahead. It's gonna be a great topic. So thank you so much for inspiring me. To my friend Roselane, she's the mother of the child that we saw in the picture. She sent me all his pictures, his videos in his dental visit, and she allowed me to share his image in his videos. And for Dr. Klaus and Tia Ho, those 2 wonderful dental professionals that definitely are making a difference in their community. So I want to thank you so much. That ends my presentation. I don't know if anybody has any questions. I will be happy to answer.
And then Kristen also put some links in the chat. I think there's an Instagram and just a couple resources and links for everyone if you want to check any of those out. This is such a great presentation. Does anyone have any questions?
Thank you. I'm seeing some messages. Thank you, everybody.
And is it okay to share that dental toolkit?
Yes, that is available in the website, the Autism Speaks. If you search dental, you have many links there for dental professionals, for parents, for caregivers, for children. So there is a lot of resource available there for everybody. In Tia Ho website, even though she's Brazilian, she shares a lot of videos in her social media, is available there. So it's great because you can see sometimes her approach with the children. She had those 2 professionals, they had no training, was just, learning day by day, making tests and now they have a line of patients, the community searching them all over because it's been so successful.
Okay, well, thank you, Christiane. It was a great presentation. Again, if anyone needs to contact her, I'm sure she can provide her email in the chat, or if you have any questions, feel free to use the chat function as well. So we're going to go ahead and transition over to our next presenter. It's going to be Angel Bradley. Angel will be talking about the effects of tobacco use on African American women and the importance of screenings. So whenever you're ready, Angel.
All right, good evening, everyone. As I'm preparing to share my screen with you all. Okay. And all right. Okay, the title of my presentation is A Breath of Fresh Air. It is a qualitative approach regarding the importance of lung cancer screening amongst African American women between the ages of 50 and 84. Again, my name is Angel Bradley, and I am a AHEC scholar under the direction of the West Florida AHEC. So just briefly, presentation outline, I will go over, I've already provided an introduction. I'll go over who I am as a researcher, the proposal that I have in place, abstract, specific aims, background and significance of this research project, the methodology, data analysis, and my next steps. So just to give you all a little bit of background about myself, I am a native of Pensacola, Florida. So I am located in the very last county in the state of Florida before you cross over to the Alabama state line. I do have a Bachelor of Arts in Interdisciplinary Social Science, Master of Science in Community Health Education, specialist degree, and a doctorate in health science, but I am currently a master in public health student attending Nova Southeastern University. So that is a distance education, distance learning program at Nova Southeastern. So as an AHEC scholar, I do work for the Department of Health here in Escambia County. So as an AHEC scholar, I am a member or participant in the Research Excellence Initiative. It's fellowship style. So the mission of the Florida Department of Health in general is to protect, promote, and improve the health of all people in Florida throughout integrated state, county, and community efforts. Florida Department of Health works to to protect, promote, and improve the health of all people throughout the state of Florida. The Research Excellence Initiative is an established year-long educational program for professionals, and that's for development and growth of Florida Department of Health professionals to conduct public health research and program evaluation. So the overall goal of the initiative is to promote high quality and innovative research at the department, to educate and recognize Department of Health researchers, and to promote research on department priorities, including healthiest weight and obesity, cancer and other tobacco-related diseases, health disparities, trauma and substance abuse, and the Healthy Babies Initiative. So with that said, my approach is on tobacco-related illnesses, as you will find further in my presentation. So just to provide a brief introduction, lung cancer is the leading cause of cancer-related mortality in the United States. Cigarette smoking is estimated to be linked to 80 to 90% of lung cancer deaths, making it one of the most preventable cancer deaths. And when we say preventable cancer deaths, just meaning that lung cancer is the cancer that is tied directly to other, yes, but cigarette use is the main, cigarette use is the main cause of lung cancer. Research shows that after smoking cessation, one of the most effective mechanisms for reducing lung cancer mortality is through annual lung cancer screenings with low-dose computed tomography. Okay, so while enrolled in the AHEC Scholars Program and the Research Excellence Initiative, I have gathered a research proposal, utilized the research through lit reviews and such to develop such proposal to go through the IRB approval process with the state of Florida to actually conduct research regarding this issue. So the purpose is to reevaluate and tailor current approaches to lung cancer screening recruitment to ensure that African-American women receive sufficient and sustained access to screening programs, as well as to assess the awareness of African-Americans that have smoked and their understanding of the importance of lung cancer screenings. So it is a two-part approach. In my research proposal, my plan is to overall increase the understanding of why they should, why they should get lung cancer screenings, as well as to provide information on sufficient and sustained access. So whether they need more research, more resources to increase their access to such screenings is why I am conducting this research project. So overall, the research question is, if African-American women were more knowledgeable about lung cancer screenings and the importance of, would it decrease lung cancer rates amongst my target populations between the ages of 50 to 84? As I stated before, lung cancer is the leading cause of cancer deaths in the United States, resulting in more deaths than colon, breast, and prostate cancers combined. So African Americans in general have the poorest survival rates of any ethnic or racial group for most cancers. So my specific aims of this study include, Specific aims of this study is to conduct in-depth surveys to assess the awareness of African-American women that have smoked and their understanding of the importance of lung cancer screenings between the ages of 50 and 84 years old in Escambia County, Florida. The methods that I will be using, it will be a cross-sectional data, and this will be collected with surveys delivered in person and online. For my research, I need 218 selected individuals from African-American women that reside in Escambia County, Florida, who are tobacco users and who are between the ages of 50 and 80. So this cross-sectional design study will be conducted to gather the data. Use of surveys will be analyzed to collect the data, and these surveys can be administered online and or in person. And the survey will focus on 3 domains, and these 3 domains include knowledge and familiarity with lung cancer screening recommendations, their attitudes towards screening and anticipated behavior regarding recommending and ordering screening for high-risk African-American female smokers. And just another statistic, 1 in 20 Black women will be diagnosed with lung cancer in their lifetime. Black women have lower lung cancer survival rates than white women, partially because of their lower early diagnosis rates. And the key word there is early diagnosis rates. On average, by the time an African-American woman is diagnosed with cancer, they have already entered stage 4 of lung cancer. So specific aims of this study include to conduct surveys with the target population, and these individuals must be tobacco users or in the past have been at least a pack per day smoker. Aim 2 is to gauge the focus on those 3 domains that I've mentioned before. And the third aim is to analyze the data to determine the target population's knowledge and attitude so that I'm able to assess the outcome and variables of the survey that is administered. So overall, my objective is to explore the motivation or lack thereof for screening eligible African-American patients for lung cancer. So just overall, these individuals are actually eligible for screening, but I want to definitely explore what is their lack of motivation. Is it because they just aren't knowledgeable of such, or scared, or fill in the blank? So I'm using surveys because this is the best tool for conducting this type of qualitative research. The surveys will pull in profound and diverse feedback from my respondents, and the results from the survey will make researchers aware of the insights that they probably had not previously considered as a possibility. The study procedures will include sample and recruitment. So it will be a random sample of African-American women between the age selected. They must be current or former tobacco users and are at least a pack per day smoker. Participants must be English speaking. Participants will also be selected from faith-based organizations, physicians' offices, medical clinics, and recruitment will also be conducted through beauty shops and solicited through social media advertisements. Consent will be provided prior from my participants so that they're able to provide me with the answers on the surveys. So my sample size, I need to reach 218 for my sample size. So with that said, I plan to survey 250 African-American women. You definitely always want to sample more than needed so that you're able to reach the results sought. And my procedure in terms of my study will be a 22 question survey. This will take about 10 to 15 minutes to complete. They will be open-ended and yes and no questions. Only the participants and the researcher will be present during the focus survey delivery, and the participants will be informed of the purpose of the research at the recruitment stage, as well as reminded during the delivery stage of the survey. The study will use the social ecological model to identify potential barriers. So in the past, recent surveys have similarly identified cost and distrust as barriers, but have also found smoking stigma and inconvenience, such as scheduling and transportation, to be issues amongst the African-American population. So this slide shows the actual questions that will be asked on my survey. And just to give you, I know it's a lot for one slide, but just to show you all just some of the questions that will be asked, just beginning by asking if we have, or if I have consent to contact them if need be for any further information, to just asking their zip code, asking for their contact information, and then just getting into those questions to assess their attitudes, knowledge, and beliefs regarding their tobacco use, and if they deem that lung cancer screenings are important or not. So overall, my goal is to increase knowledge base, prevention, definitely, and to have an overall increase in wellness among my target population. And then this just shows further resources that one can research if they are interested. Of course, American Cancer Society, Lung Cancer Association, and the National Cancer Institute. And on this last slide, you will just find my contact information if you have any questions, concerns to ask of me. And that concludes my presentation. Are there any questions? I'm sorry.
No, you're good. I was just gonna say thanks. That was a great presentation. If anyone has any questions for Angel, go ahead and just unmute yourself, or if you want to put it in the chat, we can do it that way as well.
Great, no questions.
It's just how well the presentation was. You just knocked it out of the park. No one has any questions.
Awesome. Okay, I'll stop sharing now.
Thanks, Angel.
Thank you all.
Okay, we're going to transition to our next presenter, Andre. He will be doing Occupational Therapy 101, Occupational Therapists and Assistants Living Life to the Fullest.
Thank you all. Pleasure and honor to speak to everyone tonight. It's about the profession that I love and is dear to my heart, which is occupational therapy. So Occupational Therapy 101, Occupational Therapists and Occupational Therapy Assistants Living Life to the Fullest. By me, Andre Johnson. I'm a Florida A&M MSOT student, and I'm from the Big Bend, Florida AHEC. So with that, the objectives for tonight is more or less scholars to learn about the field of occupational therapy and the importance of occupations. Scholars will learn about OT and OTA interprofessional team, and scholars will learn about the settings of practice that occupational therapists and occupational therapy assistants work in. So what is occupational therapy? I know many of you probably are going occupational therapy. I may have never heard this. Well, the roots of the profession started with the name of occupation and the essence of occupying your time. So when you think about that, that's where occupational therapy originated its name from occupying your time. But with that, let's fast forward to a modern day definition. So occupational therapy is a science-based profession that utilizes everyday activities and habits of individuals, groups, and communities to provide practical and evidence-based solutions to meet mental health as well as health and wellness needs of individuals. Those two pictures you see is one picture of an occupational therapist in a mental health setting doing a treatment group. Another one is a picture of an outpatient clinic where occupational therapist or occupational therapy assistant is performing range of motion on their patient. So it's a very varied profession with a lot of different areas that we work in. So I know I talked about that lovely word occupation, and many of you were going, occupations, I have a job. That's not what we're talking about tonight. So when we talk about occupations and occupational therapy, we're talking about learning by doing. Occupational therapy is a profession rooted in doing. When you come to us, there's going to be something that you have to do. We're not talk therapy. We're about practical strategies to what you need to do in your day-to-day practice. The biggest aspect about occupational therapy is we're trying to have you strive for you to be to the best you. And that means that, for example, depending on what type of injury, et cetera, you have, it may have an impact on how we, for example, would treat you. So when I said to you occupations, I said to you, what is that? And many of you probably said, I have no clue. You haven't told me, Andre. So I'm telling you right now, basically it's meaningful and purposeful activities. Now, the very important piece about that meaningful and purposeful means it comes from you. What those meaningful things are, we're going to use those essentially in your recovery through a medical process. So I'll give you a couple examples. Say you fractured your arm and you're a baseball player. Well, I'm going to start with the process of obviously allowing that bone to heal, but I'm going to incorporate, for example, your baseball routine into your recovery. So for example, when you want to get back into your day-to-day aspects of being an athlete, no problem. We've already tried to address that. If you want to take it to a more basic level, if we have a child that, for example, may have autism. So Christiane talked about patients with autism who are getting dentistry. A good example that we may talk about here is we may be working with that child on those sensory aspects and working on the desensitization process in the clinic so that when they got to Christiane, she would go, you know, they really tolerated that dental cleaning so much better this time than their previous sessions. So this is kind of a couple of examples of when you look at occupational therapy and you say, what are occupations? It's really whatever is meaningful and purposeful to that client to be able to help them overall in their process. So in the profession of occupational therapy, we break down these occupations into 8 distinct areas. Everything that you do pretty much throughout your day is considered an occupation. So for example, when you wake up in the morning, you prepare for yourself a cup of coffee. That is an occupation. You are feeding yourself. When you go to sleep at night, that is additionally an occupation. Of course, it's sleep and rest. But when you think about occupational therapy, that's why, for example, these occupations and how our profession may look to you, it changes drastically from therapist to therapist, from setting to setting. Because as I said to you, we might be treating a child that's literally 6 months old, or we might be treating an adult who's 85 years old. So our job is going to look very different depending on the settings that we're in. But in regards to those occupations I was talking about, they're broken down here into very succinct domains in a sense. And a way to break it down, an aspect of to look at somebody and say, you know what, maybe we need to work on their social participation. And that would be, for example, their engagement within their family or their community or in their schools. Or it might be, for example, many of us, we work, right? And we burn out. And unfortunately, the aspect that we're probably lacking is leisure. That would be something, for example, we would probably break down your day, talk to you and say, listen, you're doing a lot and I know you want to get a lot done, but perhaps maybe one of the things that we need to do for you to feel better overall is actually incorporate some rest or some strategies, everyday strategies that maybe, for example, mindfulness strategies that you could implement in your day-to-day to assist you when you maybe got frustrated with that burnout process. So this is just a simple overall understanding of occupations themselves. But with that, I more or less wanted to introduce you to the team that would take care of you when you came to an occupational therapy center. So if you would have an occupational therapist, that's what I'm studying right now at Florida A&M University to become. And you have an occupational therapy assistant. I was an occupational therapy assistant now for 13 years. So I've gone back basically to get additional training. And the reason behind that is because when you see the slide up top, the two options for occupational therapy practitioners are our OT professionals and our OTA professionals. Our OT professionals, typically speaking, if you take out all of your schooling, no bachelor's degree, anything, it's going to take you to be an occupational therapist, roughly about 5 to 7 years. You become an occupational therapy assistant with no degree, 2 to 4 years. If you have a bachelor's degree, though, it is literally 2 years, likely for either one of those options. Okay, so it's just kind of because OTs are a graduate school degree. Meanwhile, our OTA programs are more undergraduate in nature. Okay, but over here, they're kind of sculpted out. Many different programs of how they go. So I didn't want to share that with you all tonight. I just wanted to give you an overview of how to become one if anyone was interested. With that, I wanted to go into my definition of occupational therapy and what it looks like and how it shapes itself within the community. So the first thing you think about when you look at occupational therapy, it's a profession that's rooted and based in scientific principles. It's got rooted history from psychiatry as well as psychology. So that's where it talks about with its holistic scope. It much is using those principles to really treat the patient with an overall lens, not just on the physical or the mental, in combination of both. So for example, I used the example earlier about a patient with a fracture. If I was trying to have them regain motion after that injury, one thing you'd have to consider is pain. As an occupational therapy practitioner, I would absolutely ask you, what's your level of pain and what are the emotions that, for example, cause that pain to you? In doing that, for example, you are going to likely trust me more as we go through the process, because essentially, I'm telling you, I'm not going to push you to pain. I'm working with you to overall increase your occupational performance. And that's something that we generally work on in regards to occupational performance. But with that, shifting into other definition of OT pieces, opportunity. You work and serve individuals and organizations, communities to address society's needs in a variety of ways. Flexibility, many career tracks, because as I said to you, we start from the beginning of life all the way through the end of life process. So there's many processes and pathways to go in our profession. It's practical. You're not going to come to us and, for example, likely see us for 6 months and all you're going to do is talk to us. That's a very important piece, obviously, of any profession. So it's not taking away from that. But a very key piece is that in life, you're doing things. And that's something that in occupational therapy, we really, really promote. The purpose of doing, right? And if you're doing things in your day-to-day, it helps overall your mental functions, as well your physical functions tied to your mental health. So that's an important thing that we really like to stress and make sure that we address with you. It's not just your physical or your mental, it's the combination of it. Patient first. As I said to you, everything that we will do is more or less a collaborative process. You will never see an occupational therapy practitioner and them tell you, for example, I've heard nothing from you, you're going to do this. No, that's not our profession. The first question I'm likely to ask you is, what are the things in your day-to-day that you're having a struggle with? Because that's then how I'm going to first off decide, this is how I'm going to help address your deficits and your issues to get you back to that level of independence you were before. Finally, it's an evidence-based practice. Peer-based research is utilized throughout this process in our profession. So it's very important for any profession, but particularly ours, we are evidence-based in nature. The picture you see as well, that is another occupational therapist practitioner ranging a patient in a clinic. So the population of occupational therapy practitioners treat, as I said to you, the treatment of individuals, organizations, and communities from birth through end of life. So occupational therapy addresses society's needs through a variety of settings and practice. As I said to you, beginning to end of life. So many of you might be trying to figure out, how can I visualize what a day-to-day might look like for occupational therapy practitioner? Well, that's the question that's a little bit difficult because, for example, if I was a pediatric therapist, and this is some of the settings that you can work in. Some of them are duplicated because as you go in age, you could use it, right? So for example, you'll see driving rehab in an adult as well as 65 plus population. In pediatrics, you'll see hospitals. But more or less, this is an overview of all the different areas that we work in. And this is why when I'm saying to you, it's a very encompassing and far-reaching field, it definitely is. Many of you have probably walked by an occupational therapy practitioner and never even known it because they're just doing their job, what they got to do, right? To break it down in a little bit of a better example, here it is here. And then finally, what are some key characteristics of a good occupational therapy practitioner, or I should say a great one? Number one, you want to be hardworking. An intelligent lifelong learner is another process because as you think about it, life doesn't change for us at all. It keeps changing as we age. So as an occupational therapy practitioner, especially when we think about technology and advancements, for example, many of us on here right now, things like AI, that's going to change our day to day. So guess what? As an occupational therapy practitioner, I can't sleep on that and say, oh, that's not a big deal. Because if you come into the clinic and you start telling me I'm using AI, I have to implement that into my treatment plans. It's critical. An empathetic person. This is very critical. We treat people, but we also, it's a process of understanding how people are and how they feel. So I say that's one of the best characteristics and greatest ones that we have. We are very empathetic. Adaptable and flexible as a thinker. So you have to be very open-minded because as I said to you, if your patient comes in and as an occupational therapy practitioner and says to you, you know what? This is what I want to work on because this is my difficulty. That's what I kind of have to adjust that way. Or I have to explain to the patient why I can't start right there and how can I get to that process. So it's very critical for us to be open-minded and overall how we treat people, because we also would treat people from many different cultures, different countries, etc. Active listener. I think all of us on here who are medical practitioners, this is highly critical, but in occupational therapy, I must listen to you. I need to hear you. I need to hear how your day-to-day goes. So that's definitely one of the big pieces, being an active listener. People skills. We all got to work with people. Everyone on here has to do it. There's nothing worse than, I'm sure all of us have experienced it. You maybe have gone to a healthcare practitioner's office and you may have, for example, gotten a cold shoulder. Just didn't make that visit feel the same. So it's very critical. Our people skills are very important. Kindness. Well, you kind of have to be empathetic. Kindness kind of goes hand in hand. And that's something I would say to you. It's very important piece of our profession. And finally, you got to be service driven because you are overall treating your communities or individuals or organizations that need help. So it's not about you, it's about them. So that's a very big piece. With that, I just want to kind of wrap up with a couple of slides discussing salaries overall so people could see those as well. Occupational therapy assistants, as you see up top, it's about a $61,730, and this is the information from BLS in regards to the average median wage. And when we talk about occupational therapists, remember that is a higher level degree as well as graduate school considerations, and they average around $85,000 a year. Okay, both are excellent positions in regards to job probabilities going forward. But with that, I just wanted to wish all of you a happy Occupational Therapy Month, and thank you so much for your time and paying attention to this tonight. I know occupational therapy is maybe not something you've experienced, but I hope you learned a little something tonight, and it was a pleasure presenting to all of you. Thank you so much, and I will pass it on.
Thank you, Andre. That was a great presentation. I know I sure learned a few things about occupational therapy, so that was really interesting. Does anyone have any questions for Andre before we transition over to our last presenter?
I'm just curious, I'm gonna ask Andre, you mentioned, I saw the $85,000 salary range for an occupational therapist, but what about the assistants? I missed that. What is
So
that?
the assistants are averaging 61,000.
Right.
And that's going to be largely regionally dependent too. So please keep that in mind that, for example, states like California, where maybe cost of living is more expensive, may have a higher salary than others, but on average, 61,000 across the nation.
Okay, great.
Thank you all for tonight.
Thanks, Andre. Great presentation.
Thank you.
Okay, we are going to transition to our next and final presentation of the night with Elena.
All right. Hello, everybody. Thank you so much for being here. I really appreciate you sticking around to the end and coming on a Monday evening, but I'd love to present to you my research on addressing accessibility of COPD therapy for patients without insurance. So, like I said, my name is Elena. I'm in my final year of pharmacy school at Wilkes University. So I'm from the Pennsylvania region of AHEC, and I'm very excited to present with you what I have researched. So without further ado. So just to give us a little roadmap, what are we going to be talking about today? We're just going to start with a little review of the background and treatment of COPD, just to get everyone on a little minor same page about kind of the pharmaceutical thinking behind the treatment of the COPD. Then we're going to transition to that kind of bulk of the research, which is examining that access and affordability that we'll see with the medication therapy. And then we'll discuss what us as healthcare providers can do to increase accessibility to medications for our patients. So first, getting into that background and treatment. So what is it? What is chronic obstructive pulmonary disease? So it's defined as a heterogeneous lung condition that's characterized by chronic respiratory systems because of abnormalities in your airway or your alveoli that cause persistent progressive airflow obstruction. So what causes it? We can see it from tobacco smoking, outdoor occupational or household air pollution, and or some kind of host or genetic factors. So from birth or any gene deficiencies that you may have. So we know what it is, but how common or what's the prevalence of it? So it's actually a leading cause of morbidity and mortality worldwide. The global estimated prevalence is about 10.3%, and that may seem like a low number when you think globally, though. 10% of our global population is quite a bit. And the estimated global mortality is around 3 million deaths annually. So 3 million deaths every year is quite large. And kind of transitioning it more into the healthcare burden, the cost effect of this. So healthcare costs attributable to COPD are about $800.9 billion. So that's $40 billion per year in associated healthcare costs due to COPD. And that's most often kind of exacerbators accounting for that greatest proportion of the burden. And we can have these exacerbations in patients who aren't controlled. And in our situation with this research, if they can't access their medication, they're not going to be able to maintain control, and they're going to have more exacerbations and attribute to this healthcare cost to them and to the US. So just to give a really big overview of all the medication inhalers that we see approved for COPD. So this is FDA indicated COPD inhalers. I'm not going to read them all, but you have your bronchodilators, you'll have your muscarinic antagonists, and then there's combination inhalers for patients who may need 2 components or 3 components, depending on what stage they are in their treatment. So I won't read all of the inhalers, but just to see how many different kinds of inhalers we see for our patients with COPD. Into our treatment algorithm, so taking all those inhalers and kind of punching them into who gets what and where, it's kind of based off 2 things, whether our patients are having those exacerbations, so they're uncontrolled and they're ending up either in the hospital or not in the hospital, or they're having these episodes where they can't control their breathing. And it's based on some kind of assessments that you can do with your patients. So there's the MMRC dyspnea scale. So that is a grading system that just evaluates breathlessness, and it goes on a scale of 0 to 4. So it can be based on 0 if it's the best case scenario, they're not experiencing breathlessness, or 4 if they have the worst case. And then there's the CAT assessment, which is kind of bigger and more broad against all the symptomology that we can see in COPD. So it's 8 lines, and it addresses cough, mucus, chest tightness, breathlessness, activity limitation, sleep, energy, and confidence leaving home. So that's, yes, I don't cough very often, or yes, I feel that when I leave home, I'm going to be okay and I'm not going to have any breathing problems, to all the way, my chest is tight all the time. I have problems at rest. I wake up through the night for my COPD. So on the bottom left in group A, we have the lower severity. So they're not having as exacerbating symptoms. They've had no or 1 moderate exacerbation, but they haven't been in the hospital. And then in the group B, you see they still haven't been to the hospital, but they may have a little bit more burdensome of symptoms. And then this was actually just updated this year to go to group E. There used to be CD, but then they combined it into E. And now that's the highest treatment option, where you get into the patients who have had multiple moderate exacerbations or if they've been hospitalized. So I know that was a very fast overview of some kind of high level stuff, but I just wanted to give a few clue points into it. It's not necessarily the most important thing to take away from this presentation, but it just gives you a little bit of background to kind of get us all on the same page to talk about accessing and affording these medications. So there's actually a very large range in costs, from $61.38 all the way up to $1,272 for the 25 commercially available brand name devices, and that's per inhaler. So if you think of a patient with chronic obstructive pulmonary disease, that is not treatable. It's for the rest of their time. And 1 inhaler usually only lasts a patient 1 month. So that's a patient every single month coming to their pharmacy and picking up $100 to $1,000 medication. And in our specific population that we're thinking about now, these are patients who don't have insurance to help them cover their medications. And they may have some considerations where it's buying groceries for the week or it's getting their chronic medications. And when you have a medication that can range from $60, which may not seem like too much to most of us, but it can be so much to some people, all the way up to over $1,000, which is definitely a lot to me. So, and then keying in that these are brand name devices. I know maybe if you're not familiar with pharmacy, there's brand and generic, but where there's 25 brand available names, there's only 10 commercially available generic devices. So where these are an option for our patients, they still range from $28 all the way up to $590. And again, when it's a decision between feeding yourself and your family for the week or affording an inhaler, it's kind of tough for patients to decide what they can do, especially if they don't have insurance. And I know it's focused on patients without insurance, but putting it in the light of patients with insurance, I've still had people come to my pharmacy with their insurance covering these medications, and it's still $300, $500, and that's what they have to pay if they do have insurance. So it's kind of just something to put in perspective with how expensive these things can be sometimes. And again, this is per 1 inhaler. So if 1 time a month, this patient is picking this up. So what can we do to kind of help in these gaps where these things are so expensive when we have patients who can't afford them? And that's where patient assistance programs can come in. So what is a patient assistance program? Essentially, it's just a program that's sponsored where we can provide these medications to patients at no charge, depending on specific criteria. It's not a coupon card or an insurance, so it's not something where you take $25 off or you pay your deductible and then it starts to kick in. It's where a patient will sign up and they'll get accepted, and then it'll be free medication for them. And it's most often sponsored by pharmaceutical manufacturers. So they'll create their brand of the medication, and then if you go onto their manufacturer website, they can have the option to have these assistance programs available. And like I said, it differs in availability and eligibility criteria. So as we'll see when we get into the actual research portion of it, not every inhaler is going to have a patient assistance program, and not every patient is going to be eligible for the patient assistance program if it is available. So how can we find them? Not everyone learns in school about these programs, and not everyone knows where they are. So I want to equip you guys with the option to be able to find these for your patients, even if you're not in pharmacy or even if you are not in the healthcare profession, you can do this for your friends, for your family, for people you know, if you know they're struggling. You can search manufacturer or medication websites. So even just typing in Google the name of the medication and patient assistance program, you can find it. And there's also websites and resources available to help in the search. So this is one that I use specifically and I learned in school, which is needymeds.org. And if you go online there, you can type in the name of any medication and it'll show you patient assistance programs, but it'll also show you coupon cards and other programs that patients can go to for help, not all limited to patient assistance programs. So through my research and dive into these different patient assistance programs, out of the 25 commercially available brand name medications, inhalers, 18 of them have patient assistance programs. So these are only the ones approved for COPD. So this isn't inclusive to asthma, even though some of them combined, but so 72% of all inhalers have the patient assistance program, which is a pretty good percentage, especially because sometimes you can get alternatives where the same medication components may have different brand names and one might have an assistance program and one might not. So this is a pretty uplifting percentage compared to those kind of high expensive things we had to look at before. But I took a smaller scale view into these patient assistance programs. Rather than looking at 18, I was able to identify 14 inhalers based on the 2022 top 200 most common prescriptions, because it's one thing to look at all of them, but seeing which ones are most commonly prescribed to our patients will give us a better light in what patients are actually getting. So of the 14, there was still a high percentage of 71.4% of inhalers had patient assistance programs. So 10 out of that 14, and I listed them there below for you. And they came from 4 different manufacturers. So a bunch of these inhalers were manufactured by the same company, and they came from Teva, GlaxoSmithKline, Boehringer Ingelheim, and AstraZeneca. And when I was looking into the programs, I was looking for eligibility criteria that included if they listed what their income criteria was, because oftentimes you had to be of a certain percentage of the federal poverty level, or you had to have a certain income annually or per month based on your household size. Need to provide proof of income. So that was considering if patients had to submit a pay stub, or if they had to submit their tax information. Presence of other coverage. So if they allowed patients to have something like Medicare or another state program or private insurance, if they were residents of the US, and if they have US citizens or a social security number. So a lot of our patients without insurance may be here and be working to get citizenship, or may not have a social security number, but they deserve just as much access to these medications as others do. So kind of investigating if these are accessible to all of our patients. So based on the 14 inhalers we saw, these are kind of the statistics that I got out of it. So only nine of the 10, they listed out whether you were a certain percentage or what kind of income criteria you had to meet. Half and half determined if you needed proof of income. So half of these programs required you to submit either a pay stub or a tax information, and they go more into depth on exactly what you need. 50% of them allowed you to have other coverage, but 50% required that you had no access to any other kind of coverage. 100% of the programs required you to be a US resident, and 50% of them required you to provide a social security number. So you can kind of see that even though we have this amazing thing that we can provide access to our patients, not even all patients are going to be available to use these because they won't meet the eligibility criteria. So what can we do to kind of help bridge this gap, whether it's using these patient assistance programs or other things that we can consider as healthcare professionals? So we can assess adherence, safety, and efficacy of their medications. We can look into some non-pharmacological recommendations. What can they do on their own without the use of medications? And finding available resources. So being that guide to help people find the things that they need. So adherence, safety, and efficacy, these are really big things that we think of as pharmacists and in other healthcare professionals as well. So if they're out of pocket paying for this medication, what can we do to ensure that it's working for them and that they're using it properly so they're not spending money on something that's not actually helping them? So it has assessing adherence. Are they taking it and are they using it properly? So if it says 1 time a day, are they using it 1 time a day, or they're using it just as they feel that they need it? If it's a maintenance medication and they're only using it as needed, that's not really going to help to control it. So it's not really worth the money they're spending. How often do they miss a dose? Again, if they're supposed to take it daily, if they're only taking it once a week, is that really being effective for them? And is that worth the money that they were spending on that? Device technique, even if they're taking it as they needed, are they getting the full dose? Are they inhaling it properly? Is it going to work for them? And what we can do is recommend combination inhalers too. So like I said in the beginning, where you can have those combinations, that would be better than giving a patient 2 individual inhalers and expecting them to, instead of using 1 inhaler once, using 2 inhalers for 1 dose. And that can also help with the cost thing too, providing them 1 rather than 2 prescriptions. We can assess safety. Are the inhalers in date? Sometimes, most often, patients will also need to have a rescue inhaler, and that's one that they only take as they need. So maybe they are controlled and they haven't needed it in a couple of years, making sure that they have an inhaler that is in date. So when they do need it, they're having medication that's effective for them. And are there any interactions or adverse effects? Sometimes a patient could be not taking their medication because it's causing an effect that they don't like, and we can switch them to something different that would allow them to take this medication. Or if there's any interactions, maybe there's another medication that they take that's decreasing the efficacy of the medication, and now they're taking it, but it's not really working for them. And then moving on to assessing efficacy. Is the medication working for them? Are their symptoms under control? Is the disease progressing even more? Because these are all things that we can do to make sure that the therapy is worth it for them, and the therapy is something that's actually helping them. So onto the non-pharmacological recommendations, things that can help specifically patients with COPD in their treatment, which is smoking cessation. We saw that one of the main causes for COPD was tobacco. So you want to ensure that they're getting the help that they can with smoking cessation. And a good thing is the quit lines actually for smoking will provide free nicotine replacement therapy if they call over the phone. So that's another option for our patients without insurance. They provide help counseling you through it, and then they can also mail to you some free things to help you with your smoking cessation. Avoiding triggers. So like we said, some of this can be induced by pollution. So if there's something that you notice that causes your symptoms to get worse, avoiding that. Vaccinations. So there's a lot of vaccinations that are recommended for our patients, whether it's COVID, flu, shingles, pneumonia, to kind of help prevent them from getting diseases that will kind of exacerbate their COPD. There's self-management and education. So having patients learn about the medications, learn about the disease, learn about what triggers they may have and how they can kind of understand and manage this on their own. Physical activity we know is helpful for pretty much any kind of disease that you can have. And pulmonary rehabilitation, which is kind of working with your interdisciplinary team to kind of, whether it's learning breathing exercises that help open up your lungs, or increasing your exercise tolerance, and other things that can kind of help you to gain that better quality of life. So what are our available resources? These are all things that we can do to kind of help our patients. So like we talked about, patient assistance program. So Googling the medication followed by patient assistance program and seeing if they have that, and then researching what the eligibility criteria is, because it's great if they have it, but you have to make sure that your patients are eligible for it. And then there's coupons. Coupons can be available if patients have insurance or do not have insurance, and those can come also from manufacturers. Or there's coupon programs. I'm sure everyone's heard of GoodRx, and there's other ones like Silver Scripts that you can just find online and based on your location in your store. And there's also store discount cards. I know I work at Wegmans Pharmacy, and we have just a discount card that we can put on medications if patients don't have insurance, and that can sometimes bring it down for them. We can use references for techniques. So if you are teaching your patient how to use their inhaler, you can use the teach back method, which is essentially you're teaching it to them and you're asking them to show it back to you. So in that moment, you can see and assess what their technique is, where their areas of improvement can be, and get on that same page there. There's also videos and other online sources on these inhaler websites, and on YouTube, you can see how to properly use the inhaler. And in every inhaler package, you should have a package insert that sometimes has step-by-step directions on how to use it. But it's proven that the teach back method is the most successful in teaching patients how to use it, because it's that one-on-one kind of assessing what they are doing when they're in the moment. There's also 340B locations. I'm not sure if everyone's heard of the 340B locations, but they're essentially pharmacies that can be contracted with manufacturers, and it allows them to purchase medications at a discounted price so they can make it available at a lower price for patients who are eligible. So researching areas in your location, whether it's a hospital or a community pharmacy that are eligible for these lower priced medications. And then your best resource is your healthcare team. So interdisciplinary management is key. All of those things we talked about, whether it's prescribing combination inhalers so they can pay for one instead of two, asking your pharmacist to check drug interactions, and we can look at symptoms and device technique. Social workers to help find different resources in your area, and any other healthcare member or team involved to kind of get that multidisciplinary approach to kind of find these things to increase access for your patients, and also make sure that when they're using it, it's worth it for them. But with that, I would like to open up for any questions. I really appreciate you guys listening, and I hope you're able to take something from this. And it kind of goes beyond COPD too. All of those resources are for any disease state. Any patients can have patients assistance programs, whether it's for diabetes medications or any other kind of high cost medications. So.
All right, thank you, Elena. Does anyone have any last minute questions?
I just want to make a comment, Elena. Thank you. The resources, there were some resources here that I never heard about it. Very useful for all of us. Thank you. Thank you.
Yes, I agree. There are definitely some resources that I will be looking into. So thank you for sharing that. Okay, if there's nothing else for tonight, I want to thank everyone for taking the time out of your day, out of your evening. A special thank you to our presentations. Everyone did such a great job. Kristen did go ahead and add a Google form. So this is something, these kinds of presentations, this kind of webinar is something we want to offer to scholars in the future. We want this to kind of be an ongoing series for anyone who just wants to share. Again, there's something they're doing in school, maybe with the community, maybe it's research or something that you're super passionate about. We really want to learn from all of you, just like we did here tonight, and it's a great opportunity. So Kristen did put that form in the chat. We'll probably be doing one maybe in the summer, but definitely in the fall. So if you're going to be hanging out in the Scholars Program for another year, if you have some time, definitely fill that out. We would love to have just more presentations and more options like this for everyone. I don't know, Kristen, if you had anything to add to that.
No, I'm having internet issues, so I want to keep it short for me. But I think you guys did an awesome job. Every single presentation was great. I learned a little bit in each one, so I really, really appreciate you guys presenting and taking the time to share this with all of the other scholars and everybody else who's attended. And you gave some great information. Really proud of you guys. Thanks so much.
Thank you, everyone. Have a good one.
Night.
Bye. Bye, everybody. Night.